Hello everyone. As a part of continuous cardiac education, our topic of discussion today is medical therapy versus percutaneous coronary intervention in stable angina by Dr. Dinesh Joshi sir, who is assistant professor in cardiology department at UN Mehta Hospital and having 6 years of experience in the field of interventional cardiology. Looking forward to your kind presence. Thank you.
Good morning everyone. Myself Dr. Dinesh Joshi, Assistant Professor, Cardiology Department, UN Mehta Hospital. As a part of online teaching program from UN Mehta, today we are discussing on the medical management versus PCI in chronic stable angina. Now, what are the clinical classification of the chest pain, like typical angina, atypical angina, and non-cardiac chest pain? Typical angina meets three of the following criteria, like number one is substernal chest discomfort of characteristic quality and duration. It's provoked by exertion or emotional stress, and it relieved by rest or sublingual nitrates. Atypical angina meets two of these three characteristics, and non-cardiac chest pain meets only one or none of the above three characteristics. Stable angina classification, like exertional stable angina, variant prinzmetal angina, angina equivalent syndromes, syndrome X, silent ischemia, decubitus angina, and nocturnal angina. We'll discuss each and every one by one. Now, what is exertional or classical angina, which we noticed routinely in our OPD, and most of the patients having exertional or classical angina. It occurs due to increased myocardial oxygen demand during exertion or emotion in a patient of coronary artery disease. It gets relieved by rest or sublingual nitrates. Coronary artery obstruction are not sufficient to result in resting myocardial ischemia. However, when myocardial demand increase, ischemia occurs during exercise or emotional stress. The variant or prinzmetal angina, most common seen in young patients, it's transient impairment of the coronary blood supply by vasospasm or platelet aggregation. Vasospasm of coronary artery disease cause sudden cessation of the blood flow to myocardium and cause angina. Majority of these patients having no atherosclerotic plaques. Generalized arterial hypersensitivity and long-term prognosis in these variants of angina is very good. A patient may require a beta blocker or calcium channel blocker in variants of prinzmetal angina. Now, angina equivalent syndromes, patient with exertional dyspnea or fatigue rather than exertional chest pain. The fatigue and dyspnea are equivalent symptoms of the chest pain. Many patients having symptoms of fatigue and dyspnea rather than the chest pain, and during exercise or emotional stress, it's caused by the exercise induced left ventricular dysfunction. Now, the syndrome X, typical exertional angina with positive exercise stress testing. Anatomically, all major coronary arteries are normal. Reduced capacity of the microvascular in the form of vasodilation. The microvascular unable to vasodilate during exercise, though this is syndrome X and it is due to microvascular dysfunction. Long-term prognosis is very good. Calcium channel blocker, nicorandil or beta blocker are effective in this type of angina. Now, the silent ischemia is very common, most commonly seen in the patient with diabetes, autonomic dysfunction. More episode of silent ischemia than painful ischemia in the same patient. It is very difficult to diagnose. Holter monitoring, exercise testing, CT coronary angio or stress thallium may be helpful to diagnose this kind of ischemia. Now, the chronic coronary syndrome categories as per ESC 2019 guidelines. 6 category given to the stable angina patient in 2019 ESC guidelines. Category 1 is the patient with suspected coronary artery disease and stable angina symptoms. Category 2 having new onset of heart failure or left ventricular dysfunction and suspected coronary artery disease. Category 3 is the asymptomatic and symptomatic patient less than 1 year after an ACS or recent revascularization. Category 4 is patient more than 1 year after initial angina diagnosis or revascularization. Category 5 are the patient with angina and suspected vasospastic or microvascular diseases. Category 6, asymptomatic patient in whom CAD is detected at screening. Patients are asymptomatic, but asymptomatic screening result in coronary artery diseases. Now, what is the dynamic process and natural history of the chronic coronary syndromes? It start with the subclinical phases and progress to revascularization or medical management, and long-term consequences are leads to repeat revascularization, symptoms-free period, angina equivalent syndromes. These all are the time versus cardiac risk in the cases of the stable angina patient. The higher risk seen in the patient with the very high risk factor, those like the smoking, altered lipid profile, lifestyle like type A personality, diabetes, hypertension. These are the risk factor, and repeat revascularization rates are higher, and overall outcome is very poor in this category of the patient. Regular screening, lifestyle modification, regular antiplatelets and statins, smoking cessation, lifestyle modification, regular screening. These are the favorable profile of the patient and having good prognosis and long-term outcomes. Now, in primary prevention and in the secondary prevention, the revascularization is in the form of PCI or CABG is very beneficial in the moderate to very high risk patient. In the low risk group, we can kept on the medical management like nitrates, nicoron, aspirin and statin. The asymptomatic, apparently healthy subject, no past history of the any coronary artery disease, 10-year risk of the cardiovascular mortality is considered from the scoring system like ASCVD risk factor scoring that includes smoking habits, age, lipid profile, any diabetes, hypertension, any previous past history, family history. These are the various scoring system available, and we can calculate the scoring, and we can give a primary prevention in the form of the statin or aspirin. The secondary prevention, those are the patients who having the previous past history of the any ACS, and risk stratification is done, and as per the risk stratification, the revascularization versus medical management can be planned in the patients. Now, the management of the chronic stable angina, the principal goal in the care of the patient with the chronic coronary syndrome, also known as the chronic stable angina or stable ischemic heart disease, are the secure the diagnosis, assess the extent of the disease, relieve the symptoms of the patient, prevent future cardiac events such as ACS, need for revascularization and the death. Most patients should undergo some form of the stress testing or cardiac imaging to diagnose and assess the severity of the disease, and invasive coronary angiography in those with likelihood of the severe ischemic heart disease. Now, how to determine the disease severity. The disease severity determination is the very most important for guiding treatment and establishment of the prognosis. Assessment of the coronary artery disease, assessment of the left ventricular function. Low and intermediate risk patient whose symptoms are controlled on medical therapy can be managed without intervention. High risk patient or refractory to medical therapy should go angiography and revascularization. Now, how to assess the coronary disease extent, like stress thallium most commonly nowadays used, cardiac imaging, CT coronary angiography, invasive coronary angiography. The initial choice of the depends on the resting ECG, patient profile, physical ability to perform exercise test, and available technologies. Definition of the high event risk for different tests like exercise testing, like treadmill test. Cardiovascular mortality is more than 3% per year if the TMT is the positive according to Duke treadmill score. SPECT imaging or perfusion imaging, area of the ischemia more than 10% of the left ventricular myocardium. Stress echocardiography more than or equal to 3 segment out of total 16 segment with the stress induced hypokinesia or akinesia. Cardiac MRI more than or equivalent to 2 segment with the stress perfusion defect or more than 3 or equivalent dobutamine induced dysfunction in that particular segment. Coronary CT angiography or invasive coronary angiography, 3 vessel disease with proximal stenosis, left main disease or proximal LAD disease, and invasive function testing like FFR and IFFR. Assessment of the left ventricular function by echocardiography, pre or myocardial infarction, or by history or by ECG, QS pattern, symptoms or sign of the heart failure, undiagnosed heart murmur, complex ventricular arrhythmia. To determine optimal medical therapy, role of intervention or surgical therapy, or recommendation about activity level, rehabilitation and work status. Now, PCI reduced the incidence of the death and myocardial infarction in patients who presented with the ACS, acute coronary syndrome, but similar benefit has not been shown in patients with the stable coronary artery disease. Even though treatment guidelines advocate an initial approach with intensive medical therapy, a reduction in the risk factor, lifestyle modification, the PCI become common in initial management strategy for patients with the stable coronary artery disease with the high risk factor. Now, the available drugs for the stable coronary artery disease like stable angina, European Society and National Institute for Health and Care Excellence, short-acting nitrates are the first line of treatment. Long-acting nitrates comes under second line treatment. Beta blockers, uncomplicated patient, class 1A indication, previous MI or reduced ejection fraction, class 1B indication. Calcium channel blocker like diltiazem or verapamil in the like Prince metal angina or vasospastic angina are the first line treatments. Ranolazine, we all know, add-on therapy on nitrates and nicoran, class 2B indication. Ivabradine, class 2B indication. In those patients, we can't use the beta blocker or beta blocker are contraindication. Nicorandil, potassium channel blocker. Opner, class 2B and sometimes preferred over nitrates. Trimetazidine as a add-on therapy of nicoran and nitrates. Now, the intervention for secondary prevention of the cardiovascular disease: avoid smoking, aspirin 75 to 150 mg daily. Consider clopidogrel in the patient having aspirin intolerance or a reaction to aspirin. Statin, the targeted dose is different, depend upon the population, depend upon the underlying disease, depend upon the comorbid condition, but at least more than 50% reduction should be done in the indicated patient. ACE inhibitor or ARB, class 2 indication with normal LV function and class 1 indication with reduced ejection fraction. Now, the various trials, we discuss about the various trials which are done to determine which are the better treatment option in the chronic stable angina, either PCI revascularization or the medical management, optimal guideline directed medication. First trial is Courage trial, clinical outcomes utilizing the revascularization and aggressive guideline driven drug evaluation. It's a randomized trial, more than 2000 patients included, and trial tested whether PCI and optimal medical therapy OMT alone was superior in preventing death or non-fatal MI. And the Courage results shows no significant difference were found between the PCI and optical medical therapy group in MI, death and stroke. There was no difference in hospitalization for ACS between the groups. So this trial shows the non-inferiority of the optimal guideline directed medication versus PCI. Same shows the comparable result with the medical therapy and PCI in the form of survival free of ACS, in the form of mortality, benefit and overall survival. Now, the limitation of the Courage trial, only 6% of screen patient was randomized. Among 70% of patients assigned to PCI who had double vessel disease, only 36% received more than 1 cent. Only 2.7% were treated with the DAS. This is the major limitation of this study. Nowadays, the more beneficial and more advanced stent are available, and the result may be better with the DAS. 32% of the patient on OMT patient had crossed over to PCI. Excluded high risk patient and post angiography selection bias was there in this study. Now, the orbital trial, the summary shows no improvement in the exercise time in PCI versus placebo. Orbita is the first placebo controlled randomized trial of the PCI in the stable angina. Area stenosis by QCA 84% and FFR was 0.69%, IFR was 0.76. PCI was safe and physiologically effective. PCI significantly reduced the ischemia burden as assessed by stress echocardiography. In this single vessel angiographically guided trial, there was no difference in exercise time increment between the PCI versus placebo. Now, the ischemia trials, international study of the comparative health effectiveness with medical versus invasive approach. More than 5,000 patients taken in the ischemia trials, randomized parallel open trial, and its result shows the primary outcome like CV death, MI, unstable angina, hospitalization, heart failure, or resuscitated cardiac arrest at the 4 year occurred in the 13.3% of invasive group versus 15.5% of the conservative group. The secondary outcome like CV death or MI occurred in 11.7% of the invasive group versus 13.9% of the conservative group. Ischemia trial summary, as we discussed, the non-significant favorable profile with the ischemia and as compared to medical therapy. Ischemia trial limitation, unblinded trial based on exclusion criteria. The trial result does not apply to the patient with left main disease, ACS within the 2 month, highly symptomatic patient or heart failure with EF less than 35%. Trial finding may not be generalized to center with higher procedural complication rate, and the impact of completeness of the revascularization has not yet been assessed. The various trial we have already discussed like Courage trial, Bari trial, FAM2 trial, ischemia trial. These are the trials are in the stable coronary artery disease, medical guideline directed treatment versus the PCI. The primary endpoints is almost all cause death and MI, and the result of the Courage trial shows the no difference of all cause mortality and death and MI, but the quality of is improved by PCI at the end of the 2 year. Bari 2D trial shows no difference in the all cause death, but it improved the quality of life, it improved by revascularization. FAM2 trial shows PCI reduced the all cause death, MI and urgent revascularization, but no difference in the death and MI. No difference in the quality of the life in the FAM trial. And ischemia trials, as we already discussed, no difference in the CV death, MI, unstable angina, congestive heart failure and resuscitated CV death, but the quality of life it improved by revascularization. All the major trials shows the quality of the life is improved by PCI, but the difference in all cause death and MI is not significant in the both arms. Until today, the role of the PCI with the DAS implementation versus medical therapy in patient with chronic coronary syndrome shows that no or only modest benefit in the term of survival or MI, improvement in the symptoms and quality of the life. Mostly trials did not use the latest generation DAS technology. Recent trial reassessed the role of PCI in chronic stable angina like Orbita, GZ-FFR, FAM2, Dynamic 3, Pre-Multi, Compare Acute and Swedish registry. Now these are the grey zone FFR, PCI with the modern DAS in lesion with borderline FFR, grey zone versus medical therapy. 110 patients included with stable angina, lesion with FFR significant positive, means FFR 0.75 to 0.82. Signal that PCI reduced the angina frequency and improve quality of the life at the 12 month, which exceed that seen in Orbita but without patient binding. Now the FAM2 FFR guided PCI with modern DAS versus medical therapy alone. Long-term outcome shows a continuous relief of angina symptoms, significant reduction for the composite of all cause death, MI and urgent revascularization. Signal that FFR guided PCI not only reduce the frequency of urgent revascularization but also spontaneous MI, but no difference in all cause death in both arms. Combined pooled patient level analysis of FAM2, Dynamic 3, Pre-Multi or Compare Acute. More than 2000 patients with stable angina, FFR guided PCI versus medical therapy. 5-year FFR guided PCI showed a strong signal for reduction in the death or MI with a significant reduction of MI, while cardiac death or death from any cause was unchanged. Now, Swedish registry shows large observation study, more than 31,000 patients with stable angina, 10-year strong signal that FFR, IFFR guided PCI reduced overall mortality, restenosis and stent thrombosis. Implementation of base PCI practice for CCS in 2018, strong signal that physiological FFR, IFFR guided PCI is the superior over the angio guided PCI for mortality, restenosis and stent thrombosis up to 10 years. PCI result in less angina, better quality of life, less urgent revascularization and less spontaneous MI compared to medical treatment alone. The longer the observation period is, the more the benefit with the PCI. The more the ischemia documented by particular invasive testing, more the benefit is generated by the PCI. In summary, patient with angina, chronic coronary syndrome or dyspnea or angina equivalent, decision tree for patient undergoing invasive coronary angiography. This is the latest European Society guidelines. Angina symptoms. If the patient having no angina symptoms but documented angina on large area of the ischemia, more than 10% of the LV involved on stress stellium, echocardiography or cardiac MRI or strongly TMT positive, should be considered for revascularization. If the patient having no angina symptoms and no documented ischemia on stress stellium, but the diameter of the stenosis is more than 90%, significant FFR positive, and patient having LV dysfunction due to coronary artery disease, should undergo revascularization on the top of medical therapy. Now, the patient having angina symptoms, if the patient having documented ischemia on the stress stellium and patient having multi-vessel disease, identified the lesion, critical lesion with FFR and should go for coronary revascularization. If the patient having single vessel disease, then directly go for revascularization of that culprit vessels. Patient having angina symptoms but no documented ischemia on the stress stellium, then revascularization should be considered on the basis of diameter of the stenosis more than 90%, positive, strongly positive FFR in the major vessel and LV dysfunction due to coronary artery disease. That's it from my side. Thank you.